Hello, my name is Richard Smalling, and I'm a interventional cardiologist and director of interventional cardiovascular medicine at the University of Texas Health Science Center, we know as UT Health now, and the Memorial Hermann Heart and Vascular Institute. With me is Dr. Tony Estrera. Tony?
Yes, thank you, Richard. I'm a cardiothoracic surgeon working here at the Memorial Hermann Hospital, UT Health, and we have partnered together as a cardiothoracic surgeon and interventional cardiologist to be the sort of primary investigators and primary interventionalists for our experience in TAVI, transcatheter aortic valve replacement.
With us, but not here today, are a number of other key individuals, including Dr. Logan, who's an interventional echocardiographer, Dr. Hazem Safi, chairman of cardiothoracic surgery, Dr. Scheinbaum, head of cardiac anesthesia, Dr. Prakash Balan, who's also an interventional cardiologist, as is Dr. Dinktas, Dr. Loyolka, and Dr. Carr, and Igor Grigorich, who is also a cardiac surgeon. We have some disclosures related to the conduct of the trial primarily. Aortic stenosis really is a major issue, particularly in more aged patients. It really is about the narrowing of the aortic valve, which occurs over time. And as you can see on the left, the typical age of onset of symptoms is around 50 to 60 years old. Once the patient develops symptoms, then the natural history accelerates to death ultimately. And if patients present with heart failure, that slope is very steep indeed. So that at 2 years, the survival in the presence of heart failure is 20% or less. On the other hand, if the valve is replaced, as you can see on the right-hand side of this slide, the upper curve shows survival with valve replacement, which approaches the natural history without aortic stenosis. Early on, in the early 80s, aortic valvuloplasty was first described by Alain Cribier in France, and basically an angioplasty balloon, usually used for dilating blood vessels in the legs, was introduced across the aortic valve and inflated to stretch open the aortic valve. It is possible, and you can, as long as you've trained in this technique, it's reasonably efficacious, at least in patients who have severe illness and comorbidities. Typically, this is something we would reserve for patients with critical aortic stenosis and heart failure, perhaps those that have slipped into renal failure and or liver failure, in which these cases that really we would not consider them operative candidates. We can do a valvuloplasty in these patients, and if the heart recovers, then at that point we could proceed with formal aortic valve replacement, be it either open surgical procedures or transvascular procedures, as we're describing today. This just is a case summary of, at the time, an elderly retired surgeon who had had prior bypass surgery 20 years ago, who had critical aortic stenosis and developed pulmonary edema. He absolutely refused to be operated on, and at that point the only option we had was aortic valvuloplasty, which we performed successfully. We actually used left ventricular support, a tandem heart device to support the circulation during this procedure, and he had a very nice result showing a reduction in the pressure drop across the valve from 56 or so to about 29, back into the range where his symptoms were resolved for a period of months, and he went about his usual daily activities. Unfortunately, his symptoms recurred about 6 months later, And at that point, Dr. John Webb in Vancouver had amassed a series of successful transvascular aortic valve replacements and agreed to replace the valve in this individual, and he went on to live another 10 years or so after his transvascular valve replacement. Regarding the aortic valvuloplasty procedure, a number of series have been published, and early on it became clear that the risk of death with the procedure was non-trivial, ranging up to 10%. The risk of stroke was up to 2 to 3%. In addition, major vascular complications also were not infrequent. The main problem, however, with aortic valvuloplasty was the recurrence. You could not get the valve open more than a centimeter squared, which still is a critically narrowed valve, and the majority, at least 70 to 80% of patients, developed early restenosis after the valvuloplasty procedure. So it evolved to be a temporizing procedure for patients who were not considered candidates for open surgery. Dr. Cribier and others then developed valves that might possibly be introduced via the vascular system rather than through open heart surgery. On the left is the Sapien-Edwards valve, and on the right is the Medtronic core valve. Both are basically pericardial or bovine valves implanted in a stent. In the case of the Sapien valve, it's a balloon expandable stent, and in the Medtronic valve, it's a self-expanding stent. So these valves are being evaluated clinically. Interestingly, however, the Sapien valve is the first valve that has been approved by the FDA for use in humans in the United States. It evolved from the original PARTNER trial, which we'll call PARTNER 1. There were two arms of the trial. The first one on the right is the inoperable patients, the patients that were considered not to be candidates for open heart surgery, and they were randomized to either transfemoral valve replacement or standard medical care. The second arm was high-risk patients, patients considered high risk for open heart surgery, and they were randomized to either transfemoral or transapical valve replacement or surgical valve replacement. The focus on the right side of the chart with the PARTNER 1 inoperable patients, the patients had to have critical aortic stenosis with a valve area less than 0.8 centimeters squared, with a mean gradient of more than 40 and a a peak velocity of 4 meters per second or higher, and they had to be New York Heart Association Class 2 or greater in terms of heart failure symptoms. This trial was completed and published in the New England Journal in 2010, and the patient groups were well matched in terms of this TAVR group and the standard therapy group. The risk factors for morbidity were also well matched, and the outcome was really dramatic. It really is the first time an interventional therapy has shown a very dramatic improvement in survival compared to standard therapy. This is all-cause mortality on the left. At 12 months, there was a 20 percentage point advantage of TAVR over standard medical therapy. Additionally, symptomatically, they were well matched initially on the left. Then at 1 year, at 30 days rather, and in 1 year, the patients who had TAVR were much more likely to be either class 1 or 2 than the patients on medical therapy. And similarly, the valve treatment was durable, so that the valve area, the initial increase in valve area, was maintained or actually increased slightly over the course of 2 years. So there was no deterioration in valve outlet as seen previously with aortic valvuloplasty. So it appeared that This was a really valid treatment for these high-risk individuals, not considered candidates for open heart surgery, and therefore that led to FDA approval for transvascular aortic valve replacement utilizing the SAPIEN valve. The next group that was evaluated were the ones that were high risk for surgery, and interestingly, this was also published in the New England Journal in about a year ago. Interestingly, those patients did as well with the percutaneous valve as the surgical patients, and if you only considered the patients that had femoral access valve replacement rather than including the transapical replacements, there was actually a slight advantage, although not significant, for the transvascular approach to aortic valve replacement. Unfortunately, the initial SAPIEN valve is rather bulky, and it became difficult to deliver this valve in patients with small vessels, and so a smaller valve was developed. The summary was this was good, but not good enough, and we needed to look at lower profile devices. At this point, Dr. Estrera will take over and go over our entry into the partner trial. Tony?
Now, as a cardiothoracic surgeon, we deal with open heart surgeries, and Dr. Smalling, as an interventional cardiologist, has always dealt with heart disease using catheters. This technology has been revolutionary in a sense that it has brought both of our specialties together. And really, although this device was approved for use commercially by the FDA in November of 2011, this whole endeavor began with Dr. Smalling approaching our team to try to build a multidisciplinary team in really the summer of 2010. Initial talks were begun with our group, and what we came to realize is that this was a huge endeavor that required a true multidisciplinary team to build this program. So following that, we were entered and applied for entrance into the partner trial, which was approved eventually, and we became part of the Partner 2 trial, which both looked at inoperable as well as operable candidates. Now, this is an important trial because, as Dr. Smalling had mentioned, the original Partner trial really looked at the high risk and the inoperable patients. This trial was really looking at more moderate risk, or patients that could be operated upon. Now, remembering that the indications currently for undergoing any kind of TAVR or TAVR procedure required that the patient was not an operable candidate. So that allowed patients to be done commercially. But if a patient was operable, they had to be entered into the trial to undergo this procedure. So as you can see here, that this structural heart disease team, which Dr. Smalling and our team has built here at Memorial Hermann Hospital, involves a very large number of team members, including cath lab staff members, nurses, techs, cardiologists, as well as cardiovascular operating room staff, including our nurses in the operating room, our techs and cardiac surgeons, anesthesiologists who are dedicated to this technology and to this program, our perfusionists who run the bypass machine, our imaging staff, including echocardiography, CT, interventional echocardiographers, Kathleen Logan's heading that group, our CCU staff, both in the ICU and in the IMUs, managing these patients, including nurses, respiratory therapy, critical care intensivists, research nurses, research coordinators, our valve clinic nurses as an outpatient managing and following these patients. This included our stroke team here at Memorial Hermann to evaluate the patients from a neurological status, and then obviously we had to have buy-in from our administration, who have been very supportive in this endeavor. Interestingly, you have to have a track record, so you have to have both interventionalists and cardiac surgeons who are experienced in valve technologies, relatively high valve surgery numbers, as well as documented by the STS as having good outcomes, and then also a multidisciplinary team was required to be part of this partner trial. Also experience with percutaneous interventions, specifically EVAR and TVAR, allowing experience with intervention utilizing larger sheaths in the femoral and iliac vessels. So teamwork was required, which is defined as work done by several associates, with each doing part but all subordinating personal prominence to the efficiency of the whole. And this is sort of an important point in building our team. Really, teamwork, as Carnegie has described, is the ability to work together toward a common vision. And we've been fortunate to have teamwork and seeing this through for our program. Again, Dr. Smalling with Mike Gabler, who is part of the partner, or I should say the Sapien Edwards group, who were instrumental in really initiating this program for us. But it also requires true compromise, which might not necessarily be that easy between heart surgeons and cardiologists, but we've been able to come to a true compromise in building this program. My chairman, Dr. Safi, has worked with this program with Dr. Smalling as well as his team, and we've truly seen a good team building process in developing our program. So in December 2010, we got approval for entrance into the trial. We had a meeting in February which really outlined the start of our program. As you can see, it really dates back to 2010, so it takes a little while to build this team. We traveled to Vancouver as a team and met with John Webb's team there and received our training with this procedure. As you can see here, this was in Vancouver, looking at their suite and their interventional hybrid group that allowed us to witness how this all works. We went through lectures and went through hands-on simulation during this entire program, met other surgeons across the country. It was a very educational program for us. It also gave us a chance to see how the hybrid suite, the interventional suite, was set up. We had our first TAVR conference and clinic in September of 2011, in which we started discussing the details in preparation for our first case. You can see here it's a conference room by the cardiac cath conference or cardiology suites, which we set up our conference room. We have it on a weekly basis, discussing both clinical and administrative issues for our team. We did come to compromises in that these procedures are being done in our cardiac cath suite because imaging is very important for this. You have to have good imaging, and I came to that realization as a surgeon. Although we have a hybrid suite in our institution and we're building another one in the operating room, imaging had to be perfect for these procedures. You can see here one of our agendas for our valve structural heart clinic conference. These are our coordinators, Rhonda Patterson and Susan Davidson, who are very instrumental in really coordinating and running and organizing our conferences. These are some of the nurses that work in the cardiology TAVR clinic, which is held right after our conference, where it is a true multidisciplinary conference where cardiologists and surgeons meet the patients and go through their interventional plan and workup. We do have a case screening worksheet that's filled out on every patient by both the nurses and the physicians, making sure everything is met prior to discussion in our conference. We do have a checklist looking at all the significant factors involved in scoring and risk stratifying each and every one of these patients. Some of the important things being really the STS risk score, as well as all the factors that determine whether the patient's operable or not. We had mock sessions where we would meet in the cardiac cath lab in conjunction with cardiology, surgery, anesthesiology, to work out our plan both for transapical and transfemoral procedures. You can see here us going through sort of a mock demonstration on how to work with each of the devices. So we did our first case in November of 2011, coincidentally the same month that the valve was actually approved by the FDA for commercial use. And again, a distinction of commercial is that the patient was deemed non-operable. You see here Dr. Barker at the time, who has since left, Dr. Smalling and myself working on preparation for this first case. And the person who happens to be coordinating doing the checklists for every case here. It was important that we developed the checklists for these cases. There are so many things that can happen in one of these procedures, and there's a lot of evidence now looking at checklists, the same checklist they use in the airplane industry to try to reduce complications from human error. So we developed the checklists, and we go through this on every single patient that we do for TAVR. And thus you see here Dr. Smalling actually deploying the device, but again it is a true multidisciplinary approach where everyone plays a part in each and every one of these procedures. The actual valve deployment, and Dr. Smalling is going to go through some examples later on in this presentation. And then ultimately the hospital was very good in marketing and getting the word out that we could do these procedures. Again, for the transapical, we met, and for your information, most of these procedures are going to be delivered or be able to be delivered via the arteries in the groin, the femoral or the iliac arteries. But in some cases which this is not available, we will be able to, we are able to deliver these via the apex of the heart through a mini thoracotomy on the left chest. And so this is sort of one of those trials or one of those mock sessions, and then we performed our first transapical procedure in April of 2011. And so what I've really learned over this whole process, which took almost 2.5 years to develop, is that you do require a true team to build a program like this. And so the multi-society expert consensus statement was developed about 1.5 years ago to try to talk about the requirements for transcatheter valve replacement, and made a recommendation which was ultimately accepted by the FDA as a requirement in order to do these procedures for hospitals and physicians. And in essence, as you can see here, as accepted by CMS, that you have to have an FDA-approved indication for the procedure. You had to have 2 cardiac surgeons evaluate each patient face-to-face and provide a rationale of why the patient isn't a good candidate for open surgery, and that the patient can recover and have a meaningful life, quality of life after the procedure. You had to have this part of a heart team, a multidisciplinary team that included both cardiologists and surgeons who also participated in each and every one of these procedures. And you also had to be part of the TAVR, be part of the TAVR registry, which was supported by our hospital. So you can see that in building the program, you have to have true investment by your hospital administrators to accept all these criteria. Dr. Smalling?
Well, as Dr. Estrera had mentioned, in order to do the procedure, we really have to have both aspects of a cardiac catheterization laboratory and an operating room. And we have to have space for the anesthesiologist, for the echo machine, for the cardiopulmonary bypass machine, and you can see a schematic of what this looks like in this slide. And this is how it actually looks in our facility. This is one of our catheterization laboratories where we usually perform advanced peripheral vascular interventions, particularly percutaneous aortic aneurysm repair. We also do percutaneous mitral valve repair in this room, and now TAVR. At the far left are the cardiac anesthesiologists, and then in the middle are the interventionalists and the surgeons. Dr. Estrera is the first gowned person you see on the left, and then the cath lab technicians, the perfusionists, and so forth. So it's a very large tour de force. Here you can see us getting access percutaneously with the cardiac anesthesiologist at the head of the table and the echocardiographer next to the cardiac anesthesiologist. Interestingly, we also have to do a very precise evaluation of these patients, as they have to meet rather strict criteria. One of our first patients was an 80-year-old woman from Austin who had radiation therapy after breast cancer and was felt to be not an optimal patient for open surgical repair. Although her pulmonary function was okay, her valve was severe, and there was some suggestion of a right coronary stenosis. Interestingly, her mean gradient was only 34 at rest in the presence of relatively normal ventricular function, which ordinarily would not meet criteria for valve replacement utilizing this technique. It has to be a gradient of 40 millimeters mercury or more. By just giving her a little bit of dobutamine, 10 micrograms per kilogram per minute, we found that in fact her gradient increased to 44 and the velocity was very high. This is a lady that had class 2 to 3 symptoms, and so we knew she had significant symptoms from her aortic stenosis, and this allowed her to be entered as a commercial patient for valve replacement. Also, we have to very critically evaluate the iliac vessels. You can see on the left an arteriogram performed at the time of qualifying cardiac catheterization. The patients also undergo CT angios. In order to accommodate the sheath necessary to deliver the sapien valve, the largest valve is 26 millimeters, and that requires what they call a 24-French sheath, but in actuality has a 28-French outside diameter. So very large cannula, and so this can be a challenge, particularly in the elderly patients and in the small elderly women that we frequently see. Part of the evaluation also involves cardiac CT angio, where we assess the valve diameter, also the distance between the aortic valve and the left main coronary artery, which can be compromised if the left main comes off lower than 1 centimeter, or if the left coronary cusp has a large calcium burden on it, which can then be pushed up against the left main and occluded. So all of these things are considered when patients are being evaluated for TAVR. Here, it's important also to have the correct view for delivery of the valve. The valve typically is delivered so that about 60% of the valve length is below the valve plane, the annulus plane. In order to determine the annulus plane, then we do an aortogram shown on the right. Now, this particular view is important so that we see all 3 leaflets of the valve in the same plane. The CT angio can usually give us an idea of what position to put the X-ray gantry in to achieve this optimal delivery angle. And you can see that the CT angio on the left predicted an LAO projection of 15 with caudal angulation of 9 degrees. And in fact, on the aortography on the right, this angulation was confirmed. Now, occasionally, the patients do not have a good CT angio, and in the cath lab we do an injection with the rotation of the gantry around the patient. This allows us to accumulate a 3D data set, which is then transmitted to our workstation in the cath lab, and the 3D information is combined, and a CT angio is created from this data set. And in this case, it predicted a valve angulation of the gantry of LAO8 cranial with cranial angulation of 16 from the rotational angiogram obtained in the cath lab. So we have to have really excellent angiographic properties to allow us to do these cases. And here you can see the optimal orientation for valve deployment with the 3 cusps on a line, which allows us to make precise valve placement. Additionally, we require multiple monitors. On the top left is the aortogram that's frozen and allows us to use that as a guide. We have live fluoroscopy just below that to guide the procedure, transesophageal echo images or CT images projected on the top right, and then below that is the hemodynamic and ECG monitor, which is monitored continuously throughout the procedure. So it really is a tour de force both for imaging as well as for monitoring. The first case is an 81-year-old woman who was somewhat obese. She had critical aortic stenosis, chronic renal insufficiency, and was wheelchair bound and felt not to be a good surgical candidate. You can see in addition that she has this calcification in her ascending aorta. Tony, would you comment on that? What does it mean to have calcified ascending aorta? You can see with the green arrow.
Yeah, we call this the porcelain aorta. And as a surgeon, when you deal with this aorta is very calcified and hard. And in essence, any manipulation of this will require total replacement, which carries a very high risk for stroke. Because any of this calcium, when manipulated, especially during open heart surgery, these flecks of calcium can easily break off, causing stroke. So in our minds as surgeons, unless you're going to replace the entire aorta, and for most patients, especially at this age, that's prohibitive, this is a contraindication to open surgical aortic valve replacement.
This patient did have very critical aortic stenosis, the valve area of 0.4, remembering that 0.8 centimeters squared is the criteria, so half the qualifying area. A mean gradient that's twice what we would consider a candidate, so very critical aortic stenosis. Her vessels were felt to be adequate initially, and for this 22 French sheath you can see below, but as luck would have it, she really had smaller vessels. What this angiogram shows you is the balloon inflation during the pre-treatment, pre-placement of the valve, and you can see that the balloon is moving back and forth across the valve rather rapidly. You can see this pacemaker in the apex of the right ventricle. So here we are. You can see the aortogram during the balloon dilatation of the aortic valve, and I'm trying to move the arrow, but it doesn't want to move. That's all right. We'll leave. So here you can see the balloon dilatation of the aortic valve before we deliver the valve. the balloon is moving more vigorously than we like. There's a pacemaker that comes up from the femoral vein into the right ventricle, shown at the bottom left with the two little dots on it, which are the electrodes. And this was not capturing her ventricle adequately to freeze basically the heart function. So we then repositioned this pacemaker, which allowed us to then pace at a rapid rate at 180 beats per minute, which effectively allows the heart to stop beating. In order to deliver the valve, you can see we institute rapid ventricular pacing on the left side, where the blood pressure comes down below 60 millimeters of mercury and the pulse pressure narrows to less than 10 millimeters of mercury, achieving effective cardiac standstill. Now the valve is being deployed by Dr. Estrera. He's inflating the balloon. The valve then expands as the balloon inflates during rapid ventricular pacing, and then as we deflate the balloon, the heart begins to eject again, and when the balloon is fully deflated, then the pacing is stopped and the heart resumes its normal pumping function. This patient was extubated in the cath lab, and essentially all of the patients that we've done have had that occur. She was sitting up eating dinner 4 hours later, walked the halls the next day, and on the third day after the procedure, she was discharged. Now, Tony, how many of your open surgical patients have been discharged on day 3?
In essence, none. The reality is our average length of stay for most of our open conventional aortic valve replacements are usually in the order of between 5 to 7 days. So that has been impressive to me, how quickly these patients can recover from this technology and from this procedure. And more so, what is not seen in the hospital is the fact that most of these patients can be doing their regular activities of daily living with minimal restrictions within 2 weeks, because most of the conventional ones we do are limited by the sternotomy for 6 weeks. So many of these patients can get back to living their lives within 2 weeks of this procedure.
The next case we'd like to show is a lady that had been in the hospital for a month with severe heart failure and ascites. The fluid in her abdomen was gradually removed by a Lasix infusion. She lost 27 pounds during this period of time, and our heart failure specialist sort of twisted our arms to have us take this patient and replace her aortic valve. Now, in this particular case, the patient had really poor femoral vessels, but her iliac vessels were adequate for valve delivery, and so Dr. Estrera and his colleagues performed what had not been done previously in the United States in a patient with a prior mitral valve replacement. He performed an iliac conduit implant, which allowed us to replace her aortic valve in the presence of a previously placed mitral valve. This is a 3D echo image of her mitral valve shown functioning normally in her mitral position. Tony, why don't you describe the iliac conduit technique that you sort of pioneered for these patients?
And in essence, when your femoral vessels aren't adequate for introduction of these large sheaths, you have two other options. One option is the iliac conduit, in which we performed here. We make an incision on the right lower abdomen, staying out of the abdominal, staying away from the abdominal contents. We can expose the iliac artery near the aorta, and then we suture a graft to that directly and bring that graft out towards the groin, as you can see here, in which the actual sheath is placed through the graft. That's hence why we call it a chimney or a iliac conduit. The other option obviously is transapical, But in essence, if we don't have that option as an access, we will definitely use the iliac conduit, and we've done this in a number of cases, providing very good access for these patients.
So you can see that the iliac conduit has been exteriorized in the inguinal crease, and the sheath shown with the sort of the green knob has been inserted through that iliac conduit up into the descending aorta, and that's the access that allowed us to place the valves. And this went quite well. In this picture, you see an aortogram showing the absence of regurgitation through the placed valve, which it looks like a stent right there in the middle of the picture. But if you look just below that and slightly to the right, you can see the prosthetic mitral valve leaflets opening and closing as the heart beats. So this was the first percutaneous valve replacement in a patient with a prior mitral valve performed in the United States, which we did last summer. This is the gradient on the left before we replaced the aortic valve, and on the right you can see after replacement of the aortic valve with the sapien valve, there's no pressure drop across the valve whatsoever. So these valves achieve dramatic improvements in reduction in aortic valve gradient. Now, sometimes we're not so lucky. We think we can get the sheath in, and we get it in, and then when we try to take it out, it doesn't come. You want to talk a little bit about this complication?
And so this is a complication that can occur, and we've experienced it on one case, and the complication called quote-unquote iliac on a stick, in which you're trying to retract or remove the sheath from the iliac artery during its femoral insertion, and actually it denudes and in essence pulls the iliac artery off its location onto the sheath, which can potentially cause bleeding. Now, the strength of having a multidisciplinary team is having both surgeons and cardiologists being able to work together. And as you can see here on this slide, when this was quickly identified, Dr. Smalling and the interventional team were able to tamp out or stop the bleeding by inserting stented covered sheaths into that area to seal off the bleeding. And at this point, we took the patient to the operating room and was able to gain control of that area of bleeding and do a bypass graft of where the artery was damaged down to an area of normal artery in the femoral region. The patient actually did quite well from this, and really did not have any increased length of stay from this complication. But it's really a credit to the team, in my opinion, and being able to provide this patient with all the possible options that needed to be available to her to deal with this complication. It also underscores the potential complications that can occur from this procedure in general.
So if you look carefully on the left slide, there's the Viabond stent sitting there being ready to be deployed in the area of the leak, and we ultimately ended up putting in 3 of these. We had limited runoff on that side, and Dr. Estrera took her to the operating room and found that a flap had been lifted up at the site of sheath entry. So he actually sewed the Viabond grafts to the common femoral artery utilizing a graft. So luckily the patient's blood pressure stayed stable the whole time. There was no real hemodynamic compromise at any point, and so we sort of were able to dodge a bullet. But these are the kinds of things that you have to have a team in place ready to handle at any time. The other approach to getting these valves in, if the vessels are not compatible with the large sheaths is a transapical approach. Tony, you want to talk about this?
And this approach we've done in a number of cases, and this basically allows us to access the heart directly through an incision in the left anterior chest. Some of the nuances is really finding the apex in order to make where to make your incision that allows you perfect access to the apex of the heart. Now the apex of the heart, or the dome of the heart, is where we insert the needle. You can see in the middle frame with a guide wire. And now we're doing this procedure sort of quote-unquote reverse fashion, or in antegrade fashion. So now the valve has to be oriented in the opposite fashion, as you can imagine, as it would be if we had inserted it via the femoral arteries. But it can be complicated, and again, you have to have a true team here doing these procedures, and you make a sort of a suture purse string around the apex in order to insert the sheath, and then you have to be able to control the bleeding once you remove the sheath. But everything else is still the same with regards to the actual procedure. This cartoon depiction shows again the reversed orientation, as opposed to coming from the femoral arteries down through the aorta. We're coming actually through the heart, through the apex of the heart up to the valve. So it's a much shorter distance and potentially does have some advantages, but you have to make sure that you can deal with the actual point of where the sheath enters the heart and control that side for bleeding, and make sure you orient the valve in the right direction.
So there are a number of valves being developed that ultimately, hopefully, will allow us to be able to position the valve during deployment and then retrieve them and reposition them if we make a mistake. With the Edwards valve, it's pretty much all or none. Once you start the deployment, it's very difficult to move the valve up or down in the valve ring, and so there's a potential for the valve to either embolize into the aorta or fall back into the ventricle if you're not successful. And there's also the potential to develop severe aortic insufficiency if you have the valve a little too ventricular and allow the blood to go around it. So some of these valves are designed to allow you to move it up and down and so forth. And I think time will tell as to which one will be optimal, but certainly with the SAPIEN valve, we've been pretty happy with our results. We've had very good results. This is the sort of a schematic of many of the folks that are involved in doing just one case. All of these people you can see on here are involved in each case we do. Some of the names have changed, and some additional people have been added, but you can see, as Dr. Estrera mentioned earlier, we have a host of cardiac surgeons, a host of interventionalists, anesthesiologists, nurses, perfusionists, administrative assistants, cath lab personnel, CCU personnel, critical care and neurology representation, and clinical coordinators. So it's a big tour de force. We're pretty happy with our results. We've done now 53 cases through September of 2012. We started in 2011, so averaging about five patients per month or so. Most have been transfemoral. We've required the iliac conduits in 10 patients, transapical approach in 4, open surgical repair in patients who were randomized to surgery in 4 cases, and 16 patients were enrolled in the Partners 2 trial, which we really can't comment on in terms of results. In our commercial results of 36 patients, the average length of stay has been almost 6 days. We've had to go back to repair the femoral artery when we've attempted total percutaneous insertion of the valve in only 2 patients out of the 36. No patients had greater than 2+ aortic insufficiency, and in the other valve in the United States being evaluated, about 30% have severe aortic insufficiency post-placement. only one patient in this group has needed a new pacemaker, and with the other valve that's being evaluated, that gets up to about 30 to 40%. So we've been happy with the acute results. We've been lucky that there have been no deaths within 30 days in our total series of 53 patients. And so with that, I think we can pretty much sum things up. This is our TAVR team. Dr. Estrera there, as appropriate, is in the front. And then the rest of us are sort of trailing off behind there. This is just a very small portion of all the people involved in the procedure. And if you are interested in further evaluation of the technique, we would be happy to have you come visit. Or if you would like to refer a patient to the program, this is a referral number. With that, I'm going to turn it over to Tony to finally summarize things. Tony?
It has been a privilege, and I think one of the important things in this technology is that it truly is what I call disruptive technology. It changes the way we think about how we manage aortic stenosis. I think that's one of the important points here. I think the other important point really is the importance of the team in developing this program, and it's really been a privilege to work with Dr. Smalley, an interventional cardiologist, with regards to this whole endeavor, because it has been a huge amount of work to really put this group together. But in the end, it takes the best of all of our specialties to come together to really provide an excellent outcome for these patients who are normally very high risk for any kind of intervention. Thank you, Richard.
Thank you, Tony. It's been a pleasure to work with you as well. Thank you very much.